My personal favorite among the state's major fiscal policies. Medicaid is an enormous program across the country and in New York State where it offers health care to more than 40% of New Yorkers, providing primary health care to millions of low-income New Yorkers, as well as long-term care, home care, and nursing home services to seniors across New York and to people with disabilities across New York. It's also a really core site of fiscal debate in the state. The Hochul administration and the Cuomo administration before it regularly foregrounded the program as a source of unsustainable spending, unsustainable growth, and made attempts to make cuts to it. And that debate has been core to the budget for as long as I've been following New York politics, which is 15 years now. So we're very, very lucky to have here today to discuss Medicaid with us, three real experts and advocates on the program. We have Senator Gustavo Rivera, who needs no introduction. Represents the Northwest Bronx in the state Senate and is the chair of the Senate Health Committee, where he has worked on health equity and access issues, hospital financing, home care, and all the issues relevant to Medicaid. We have Lara Cassell, the coalition coordinator of Medicaid. Lara brings together advocates from across the state to advocate for expanded access and improve the state Medicaid system. And we have Elizabeth Benjamin, the Vice President of Health Initiatives at the Community Service Society. Elizabeth is an expert on a wide spectrum of healthcare initiatives and has been in New York State and has been deeply, deeply involved in moving New York towards universal coverage through programs like the Essential Plan, Medicaid, expanded coverage for all. So we're really, really excited to bring you together to discuss the future of the New York State Medicaid program, which is contentious as ever. And I wanted to start off by just asking really directly about the fiscal question here. At the beginning of the last state budget cycle, the governor described Medicaid spending as out of control and called for significant cuts across several program areas. Most of her proposals were ultimately rejected by the legislature in the last budget, but many commentators in the media, in lesser think tanks, have agreed with her that
shots fired!
that New York's Medicaid program is too expensive. We just spend too much. So I wanted to ask the panelists, is New York's Medicaid spending out of control, or is it appropriate to our needs? And make it a little more complicated. Are there places where, even if you think spending is at a good level overall, we could be spending less? And are there other places where we should be spending more? And I'll start with the Senator.
Good morning, everyone. First of all, I'm glad that you are doing this here. This is actually my old haunts. Technically, I am still a student at the New York State, at the CUNY Graduate Center. Yeah, exactly. You know where you're going to plug? I came to New York originally in 1998 to do a PhD in political science in this institution. You'll notice that I do not have a PhD next to my name. So that tells you how far I got. I'm glad to be back in these haunts, even though I can hear the political science department calling me and come back. Maybe I will. The short answer to your question is no and yes. You asked a very complicated question. Questions, some of those are no and some of those are yeses. Do we spend too much on Medicaid? In certain instances we do. I think that there's pieces of legislation that I've introduced to actually try to curtail spending in some of those places. Certainly one bill that I carry along with Paul, and I have the notes here to make sure that I get the bill number right, 7800, would actually reduce administrative overhead by removing managed care plans from long-term care. That is something that would save us literally billions of dollars. I believe that that we need to spend more as well. So I do not think that we spend enough, for example, just on Medicaid rates alone. The fact is, and I've said this many, many times, and I've got two people next to me that can actually speak at length and at depth as far as what the numbers are. We're talking about institutions all across the state who lose money every time somebody walks in the door just because of who they serve. That has nothing to do with how good they are with money or how how careful they are or how well they try to point people towards preventive care, etc. It just has to do with the fact that the Medicaid rates are garbage, and no institution can actually survive on them. So I think that we'll certainly get deeper and wider on it, but the answer is both yes and no.
Great question to start with, of course. I like to start with the notion that New York's Medicaid program spends what it spends for really good reasons. Excuse me. Very often this time of year, because it's conference time of year, there's a lot of conferences happening. And I speak in front of audiences, mixed audiences often, that don't know a lot about New York's Medicaid program, or Medicaid at all. So let's start with a few basic ideas, a few basic guiding principles, I think, that have been embedded into New York's Medicaid program from the beginning. First of all, New York has chosen to cover optional services. So we can't always compare ourselves to other states because we cover things like prescription drugs. What a remarkable thing. And other states don't cover optional services. We have chosen historically to do the right thing. We cover half of all children. Half of all children in New York are covered by a public program. So there are really good reasons why the New York Medicaid program spends what it spends. Could there be efficiencies? Of course. For instance, and we will get to long-term care in more detail later in the program, but the Consumer-Directed Personal Assistance Program, do we need hundreds of fiscal intermediaries? Probably not, but we need more than one. We'll get to that later. There are, other things that we can be doing. For instance, the state will now have continuous eligibility from birth to age 6. That eliminates huge administrative cost that is just not necessary. We can keep kids covered, and frankly, we think that there should be other ways to have multi-year continuous eligibility to eliminate administrative barriers. And there are absolutely places where we could be making some investments, including in primary care, which of course was already mentioned. We absolutely support the notion that there are efficiencies and administrative costs that need to be eliminated, including in managed long-term care, and investments that must be made in areas that we know when we invest in things like primary care will have a return on investment later on.
Larry, do you want to weigh in on this?
Elizabeth?
Sorry.
Did you want, okay. There was no parentheses behind for this question, so I didn't prepare an answer, but I have an answer anyway. So I guess I would say, what's the alternative? New York has the second most expensive healthcare costs in the country, right? So to buy insurance on the open market costs $12,000 a year for a single, $60,000 for a family. I mean, anybody who runs a small business will tell you that insurance prices are just extraordinary in this state. On the other hand, Medicaid, with its negotiated rates, whether we like health plans or not, the PMP, the per member per month, the amount we pay them, it's what, $400, $500? Even for an expensive person, it'd be a little more, but it's much more efficient. And government-run healthcare is more efficient. We know that from the federal Medicare program, right? So it's just, you have what? Because you have economies of scale, you have purchasing power. There's lots of good reasons to have a government-run healthcare system. And shall I speak the word that has no name?
Cuomo?
No. The New York Health Plan, your bill.
Oh, see, that has many names, but New York Health Plan, yes.
Anyway, so there's
So
anyway, the rational system would have, a single payer program, right? It's called the New York Health Act, that Senator Rivera has sponsored year after year we'll keep fighting that fight. But there's other things short of the New York Health Act we could do. New York was the second to last state that had all payer rate setting, right? Which meant that, and this would really address the hospital's concerns. I know I'm getting into like 5 questions deep, but they're like, Medicaid doesn't pay us enough. Well, if we went back, they said they wanted to be able to negotiate directly with the insurance carriers. The insurance carriers said they wanted to be able to negotiate directly with the providers. They all said a market-based system would be cheaper and more efficient. Well, guess what? It's wrong. When we have negotiated rates, all we have is super expensive hospitals like New York Presbyterian, and then losers, so they're the winners, right? Northwell, winner, getting bigger and bigger and bigger. And the losers are our beloved health and hospitals, our beloved St. Barnabas, and so I think we really have to think about a more rational healthcare system that embeds Medicaid as a core function of that program. So I'm gonna stop there, but I didn't even think I was gonna be answering that question, so I hope I did okay.
Yeah, I want to give everyone a bite at the apple for each question. So you can pass if you don't.
I'm start prepping now.
I wanted to pick up on, thank you so much. I wanted to pick up on the question of access and continuous eligibility you mentioned. New York has been at the forefront in a bunch of ways of expanding access to public insurance through Medicaid. Every time the federal government offers a pathway to coverage, we are usually among the states that take it. And we also have a really unique and uniquely impressive program in the New York Essential Plan, which offers, not unique, Minnesota has one too, but offers
Ours is better.
Ours is better. Exactly. So we have a really amazing coverage system. At the same time, nearly 1 million New Yorkers continue to lack health insurance. And that's for a few different reasons. It may be because their immigration status doesn't allow them to access care. It may be because they struggle to navigate the system and the bureaucracy we're all familiar with to find coverage, or it may be because they're not eligible in some cases. So I wanted to ask, how do we address that challenge, right? Like, how do we get that number to what we all believe it should be, which is 0, and come to offer every New Yorker insurance? I think big picture and also next year.
Hint, hint, that should not be our focus. Our focus should not be on getting everybody insurance. Our focus should be on getting insurance out of the business of providing health care. Because that's not what they actually, let me correct myself. The business of insurance companies is never to provide health care, it's to deny you care so they can keep their money. So our goal should be to actually, certainly while we work our way up to passing the New York Health Act so that we can get out of the profit-making business and as far as healthcare is concerned, at least in the providing for the insurance market. It's funny, when they do when you get a profile or something, right, they put a picture of you and they put like a quote underneath of something you said. And there was an interview that I gave a couple of years ago, and underneath it was like a picture of me and it said underneath it said, "I want to destroy the business model of insurance, of health insurance companies," unquote. I was quoted correctly. That certainly is what our goal should be. While we're working our way up to that, the state can actually, if the state is so hard up for money, why haven't they done coverage for all? That is one thing that I want to make sure that we linger on for a second. Because if state or fiscal watchdogs are whining, and I said it with a G, whining about the expenses in Medicaid, then why are we not doing more to get coverage for all, which would give us federal dollars to cover, to extend the essential plan to undocumented folks who are currently costing the state hundreds of millions of dollars in emergency Medicaid? Why are we not doing that? So let's just be honest. And so I'll stop there because I could certainly talk about this for a while. But our goal should not be to get everybody health insurance. Our goal should ultimately be to get rid of health insurance.
So I agree, obviously. So coverage for all, just for those of you that don't know what it is extending health insurance coverage to immigrants who do not have status. And other states have moved forward through what they're called these waivers, these permissions you filed with the federal government, through their 1332 waivers, with those savings, with that surplus money, by doing various innovations, in this case buying cheaper essential plan coverage than marketplace coverage, full price coverage, right? We have this big windfall, and our windfall is even bigger than we thought it was. It was supposed to start around, oh Jay, help me, $800 million a year, and then kind of ramp up to 1.3 surplus every year, $1 billion a year. Now it's even bigger. They have an extra $1 billion for this year alone. To cover immigrants would cost anywhere, it would basically, we wouldn't even have to spend that whole $1 billion, right? It's the bottom line. It'd be around $600 million a year, or $500 million a year. So we have the money. The federal government would pay for it for free, but politics, unfortunately, are getting in the way. And I'm not the political expert in this room. I'm sure many of you are. Obviously, coverage for all would be a really important first step. The other thing that I think is really important to think about is really giving. And there were sort of two other reasons why people don't have coverage. One, just the bureaucratic nonsense of having to recertify every year. Our state is moving forward saying, look, we care about our children so much, 0 to 6, it's not like people's incomes fluctuate. Once your kid's on Child Help Plus or Medicaid, it's not gonna change year over year. Let's just have them for the first 6 years of life be continuously recertified. We should do that for everybody. Why do we have to have everybody annually recertified? People's incomes actually you don't win the lotto very often, right? So it's like 1 in a billion, I don't know, you tell me the odds. But anyway, it's really, we should just have 2 years recycling, recertification, so we're not cycling people on and off of coverage. That said, our marketplace has done an extraordinary amount of work to make sure that recertification process is as least burdensome as possible. But there's still people stuck at the local districts where it is extremely hard to get through a written 7, 8, 9 page Medicaid application. I'm not sure what it's up to right now. The other thing I wanted to say is, and I think you missed this, Michael, affordability is still a problem. We are so lucky that the Biden administration and Congress put together through the Inflation Reduction Act enhanced federal subsidies so that people could get good coverage through the marketplace. And our state went one step further with that surplus funding to even improve for people above 250% of poverty, to really make it very affordable, and to kind of really crack the deductible nut. What's a deductible? It's how much you have to pay up front before your insurance actually starts paying anything. And right now in our state, the normal deductible for a silver plan is $1,300 a year. Why should anybody in their right mind spend, whatever it is, hundreds of, even with the subsidies, I think it's thousands of dollars a year before you even to buy a plan that you can't access until you spend another $1,300, right? It makes no sense. So we really have to think about health insurance design. It's designed badly. So last year, the Hochul administration said, why are we putting any barriers for buying what? Insulin, which is Senator Rivera, year after year, you were fighting to get rid of it. Go pay back. And then we got the Hochul administration said, forget about his bill, $35 a month cap, forget it. I'm saying 0, and we enacted that. That's smart thinking.
By the way, I encourage the governor, if she's listening, to take many of my bills as your own. I will go the leadership of this governor is outstanding. I will stump for you in español todos los días. Claro, que es la buena. Do that.
It's like she's like, I'll see you and I'll raise you one. Okay, fine, yes. So anyway, but we could be doing that with so many things. There's all these chronic conditions. Why should anybody pay a copay for a statin? We don't want people to have heart attacks. We don't want people, right? So let's start thinking through how we design insurance and get rid of any cost sharing for the kind of care we want them to get into. And I have a whole conversation about primary care that I'm pausing right here, but I would like to get back to that later because I think I ran on a little long.
The only other thing that I would add is to put a slightly different frame on coverage for all versus emergency Medicaid, which the senator mentioned. Emergency Medicaid, just so we're all clear, is not really actually Medicaid coverage. You're not getting a Medicaid coverage option that will provide you with comprehensive benefits. Emergency Medicaid is bare bones Medicaid coverage, which really was, I'm not going to say perhaps how the intent of how it was designed, but really is a way for hospitals to make sure that when they are treating someone who's uninsured, they can get paid to do that. It's really not about a person getting coverage. So calling it Medicaid is maybe even a misnomer, because it's not really Medicaid coverage. And the other alternative that we have right in front of us is real coverage. It's an affordable coverage option that we could be providing to people. And we all know that when people are covered, that there are, long range benefits to having more people covered. We know, of course, the ultimate goal is no insurance, but for right now, more people being insured, of course, is what we want, rather than having this thing called emergency Medicaid, which is basically not insurance coverage.
Yeah, that's right. Thank you so much. I think the ultimate goal of eliminating private insurance is obviously one we're all sympathetic to, and there's a lot we can be doing in the short term as well. I wanted to move a little bit towards questions of providers and provider health. So Medicaid is a major funder of hospital services in New York, and particularly for safety net institutions, which often serve low-income individuals and families. And New York State's hospital system is another sort of controversial area. There are 70 hospitals in New York. That's about a third of the hospitals in the state that are classified by the Department of Health as financially distressed. That typically means without ongoing operating subsidies from DOH, those hospitals would be at risk of closure. At the same time, advocates, and particularly a group of unions sort of anchored by 32BJ, has been calling attention to the fact that other hospitals in the state are making money hand over fist as nonprofits. They're not literally profitable, but they're bringing in more money than they need to keep the doors open. And in big picture, hospital prices are a major driver of overall healthcare inflation. So it's sort of a tale of two cities in the hospital area. How can New York move toward a more equitable hospital funding model that ensures both broad access to care and also affordability? And I'll kick it to the senator first.
As the New York Health Act would help, but that will be my, just assume that'll be the answer to most questions. That will actually either solve the problems or make it so much better. But what can we do now? First of all, we have to think about the fact that, let's talk about the institutions that are at risk. I spoke about them earlier, I'll repeat what I said. Most safety net institutions around the state, because of who they serve, cannot help the fact that every time somebody walks in the door, they lose money. So we need to do better at Medicaid. By the way, we should remember that the COVID-19 situation made it much, much worse, because they still had to provide care while a whole bunch of procedures that would be elective procedures that actually they counted on for some little revenue they didn't have. So you put low Medicaid rates, which have been garbage forever. Then you take that enormous dip in revenue over that year. Certainly there was federal dollars, but federal dollars have not gone away. So you have these institutions that, and this happens, I've been here 15 freaking years, right? And then in the legislature. And I remember even as a junior senator, just observing the last administration, and unfortunately this is one of the things that this administration has continued to do, they know how institutions are doing. This is not a surprise. Not only because they keep the numbers, but because the institutions come to them and beg them for help before they're almost at the edge of the cliff. And then when they're about to fall off, the state goes, okay, here we go. Here's a couple of dollars so that you don't fall off the cliff. So it seems to me that there is a lack. It's not that this is not known. There are many folks who are far smarter than I am, two other words of mine over here, that can certainly speak about what we need to do. The problem is political will. There needs to be a long-term commitment to investment, which fiscal conservatives are going to call expenditures, but we have to refer to them as investments and try to get people to understand, if we don't make these investments, as we have not in years and decades past, we're only delaying is the inevitable. and that is these institutions almost falling apart because they can't keep their lights on, or they have to choose what they do, whether they keep this light on or keep that elevator running, because they're basically running out of money. So I think that there's much that we can do there. There's actually, and also we have to remember other institutions, not just hospitals, for example, FQHCs, which have not had their reimbursement rates changed since sometime in the friggin' 90s. And they, again, serve an immense amount of population. That means they lose money every time they open the door. So I think that we need to do that as far as investment. I'll throw it to these folks I'll probably say ditto on most of the stuff they said about the rest of the hospital, but I'll pass it on.
So, I think I want to return to this notion that in the 90s, the original sin was just gutting all our healthcare planning and rate setting processes and completely abdicating under the Pataki administration to a deregulated, market-driven hospital reimbursement system, right? And at the same time, the other thing we did is we got rid of our local health planning authorities. They were called health systems agencies, and we adopted a council called the Public Health and Health Planning Council, which is our certificate of need process. And under the Public Health and Health Planning Council's wisdom, and I just want to point out that the number one, it's a group of individual stakeholders, but there are more hospitals than any other stakeholders. So you have this level of apparent regulatory capture where the agency's major decisions are being abdicated to people. For example, the chair of it is Jeff Kraut, who is number 2 at Northwell. So it's kind of difficult since he's supposedly recusing himself from all the decisions that relate directly to Northwell, but he's influencing every other decision in the state. So it's not great. And why does that matter? Well, just looking at the most recent decision that they looked at was Northwell wants to, which is already the biggest hospital system. And why do we care? Why is bigger not always better? Bigger, actually, if you have a bigger healthcare system, there's all the academic literature says it's more expensive. So why does New York have the second highest healthcare cost? Well, our hospitals have been encouraged for the last 2 decades to merge, acquire. So Northwell says, I want to take over New Vance, which are a couple of hospitals here and a couple of hospitals in Connecticut, and we're gonna, it's gonna be cheaper and higher quality. Well, guess what? And we're gonna improve their operating margins. Well, when you look at New Vance's operating margins, they were better than Northwell's for 2 out of the 3 hospitals, and their quality of care was better than Northwell's. So there's no public benefit for Northwell getting stronger and more expensive. So we have to set up a system that's independent, like California's Office of Healthcare Accountability. By the way, we're not alone in this. Other states are moving forward. So California's established an Office of Healthcare Accountability. Oregon has a health planning system. Colorado has a healthcare planning system. We cannot just sit here like bugs on our backs with our little legs up in the air being victims to a market-driven system that's broken and is not working for us. We are not getting what we're paying for. We have very low quality indicators. We have very high hospital preventable readmissions, even having spent $8 billion with our so-called disrupt waiver in the late 2000s. 2015 to, I never got to 2020. So it's just really problematic, and we don't want to close those 70 distressed hospitals. Like there was a whole hospital base closing commission in the 90s called the Berger Commission. We've way gone beyond any of their recommendations. We're now getting to a place where there's real shortages of beds in places like Queens, the Bronx, and throughout the state. And so we don't want our little tiny critical care hospitals that are on that list of 70 to shut. If they're distressed, we should figure out a way to restructure our Medicaid rates or all payer rates so that Medicaid pays more to the distressed hospitals than to New York Presbyterian. New York Presbyterian doesn't need the money, right? So I think we have to really think through in a logical, independent way, because we cannot just let a bunch of industry experts deciding the health planning of the state, owners, like people that already have stakeholders, industry interests is what I'm trying to say, make our decisions for us.
Yeah, the only other thing that I'll add, and the senator alluded to this, and I want to pick up on the word independent because I think that's so vitally important. The lack of transparency in how all of this funding actually happens is abysmal. It's, bugs on our backs is like a really good description, trying to figure all of this out, and now that we have Michael here digging in on these numbers, it's extraordinary. Trying to figure out these pools of money and where they go and who makes decisions about where the money goes. It's a system that has sort of come to be at this point, as the senator said, because the hospitals come knocking on the door to say, I gotta keep my doors open. And so they create another pool of money to figure out how to keep hospitals' doors open. And that's...
Meanwhile, closing many beds.
Yeah, at the same time closing beds. And other programs like maternity and you know, lots of other services. So I think transparency, no matter what kind of system we land on, which, you know, I think what Elizabeth said is absolutely right. Whatever we land on needs to be transparent and independent.
Thank you. I wanted to shift focus to something that I think a lot of people don't realize Medicaid pays for, but that Medicaid is an enormous payer for long-term care in this country. If you need home care or nursing home care, Medicare typically will not cover that in the long term, and so Medicaid is the primary payer for long-term care in New York and across the country, and that's a very large share of the total cost of the Medicaid program. And it's been in the news lately because, you know, there's a presidential election going on, and Vice President Harris has recently proposed actually adding a universal long-term care benefit to Medicare. That's an ambitious demand. It's been a long-standing progressive demand. There was an effort to do it as part of the ACA that didn't work. So it's not clear whether, even if God willing, Vice President Harris is elected, whether we'll get action at the federal level. But here in New York, I wanted to ask, how can we make progress toward that goal of universal access to long-term care? I'm considering it not just as sort of a safety net program, but as a fundamental right. And what should New York be doing? Has New York made progress in expanding access to long-term care in the past few years, and what should we be prioritizing in the next few years?
I said, pass the New York Alpha. That's why I started. Let's start over there and work over this one. Long-term care.
Okay, I think I'll start on this one.
Yeah.
Okay. I don't know about expert, but we'll try. So, yes, New York spends a lot on long-term care, and that's because if we didn't, people would go without, and that means they would be languishing in hospitals and or nursing homes, or, let's face it, be in even more dire straits, like being unhoused and dead, yes. So there's a reason why we pay for long-term services and supports. It's a necessity. We must do it. And I'm surprised that what the senator didn't start with. I know he has to start with the New York Health Act because that's very, very important, and we all agree. The notion that we have managed long-term care plans administering Medicaid, the Medicaid benefit for long-term services and supports has really become a completely out of control scenario where we have managed long-term care plans that are, you know, systemically denying people hours, yet taking in enormous profits. Medicaid Matters actually did a report on this in 2016, and we could probably issue the same exact report about how there are systemic denials, and the plans do this on purpose because they know that people can't fight them. So let's do away with that administrative cost. There's just no reason for it. There are lots of reasons why managed care works in other scenarios, but it just hasn't worked for long-term care. And it's an experiment that we need to stop imposing on New Yorkers.
And the reason I didn't start is because I needed the person who's smart, far smarter than me, the scholar, to be able to provide some of the, as she said, there was a report back in 2016, so it is not a new thing. This is a failed part of the experiment, folks. We need to get away from this. If we excise managed care companies from this field and we move to a fee-for-service model, we would save ourselves billions of dollars. Then we could reinvest into the system, and that means not only providing the care, but actually making sure that the people who provide the care are paid better and can actually maintain themselves. So we can stabilize that workforce and actually grow and strengthen that workforce. So the thing that I love about this bill, by the way, 7800, the reason I love this bill, one of the many reasons I love this bill, is because it will be, and I really think that there is a lot of, there's more momentum on this than other things that I've seen before. And so I am more than willing to put a lot of eggs in that basket, because it would actually be a proof of concept, so to speak. What happens when you take out the middlemen from the process of providing health care? What happens when that, I gasped again. I gasped earlier when you talked about the fact that wealthy people don't run away when we charge them a couple more shekels. And I gasped again at the idea that if we take insurance companies out of the business of healthcare, then we actually get better care and spend less money. So that's one of the things that we do.
Thank you. I wanted to ask to get a little bit further into the weeds here, because there's specifically can you talk about how eligibility rules have changed in recent years and sort of what direction, specifically for long-term care? Because I know there's been some movement in I think, progressive direction in terms of the numerical limits, but the look-backs have been bad. Would you mind sort of talking us through that and where we should go next?
Yeah, I can try. It's complicated, but I can try. The asset test is a mechanism in our eligibility system that was eliminated for all adults except for older adults and people with disabilities. We, Medicaid Matters and Community Service Society and many other groups had a few years ago now established an eligibility equity agenda because older adults and people with disabilities have not had the same rules as it relates to access to coverage. And one of the things that we were able to win was raising the income eligibility for older adults and people with disabilities. It's based on the type of budgeting that they have, the reason that it's called non-magi versus non-magi budgeting. We don't need to get into the details, but we were able to get the level for non-magi, the people who have their budgeting done that way, older adults and people with disabilities, to be the same as all other adults. That was a win. And part of that agenda is also eliminating the asset test. There's just no reason for it. We believe it's an equity issue, and we need to repeal it once and for all. The governor actually proposed to repeal it, and then in the magic of the budget negotiations, it fell off the table. The senator's laughing for good reason. The way these things happen, it fell off the table, but this is something that we believe could be an investment and an efficiency, frankly, that would allow people better access to long-term care.
Just to amplify that a little bit, so the old rules were people who were older and disabled, you had to be below 87% of the federal poverty line. So you had to be poorer than poor, right? Now that's been moved up to 138% of the federal poverty line, so you get to be a little less poor. So that's great, and it's really great we did that. I mean, many states are still stuck at not even covering older people and people with disabilities practically. So that's good. But the asset test we did get that, and the asset test is very, very low. You can only have 20,000. What? A little higher, 30,000, something like that. But yeah, it's it's very low. But we did get, for working people with disabilities, that pushed up to $300,000 in assets, which is really, so people could have a home, for example, things like that, maybe a car. you know, maybe a retirement account, like, I don't know, but, you know, I'm not sure. But I think we really need to do some equality here and have older people's asset tests at least be 300,000. And the reason why it matters is you're stuck when you have an asset test going rummaging through people's lives. Do you have jewelry? Do you have cars? Do you have a second car? Do you have an account here, an account there? How much do you get in disability? Do you have a pension? Blah, blah, blah. And so it ends up being a very long, tedious paper application, and we want to get rid of that. We don't want people sending their paperwork back and forth. We just want to have things on an electronic healthcare system through our New York State of Health website. We want to make it easy, and the only way to make that really a reality is by getting rid of that asset test entirely.
I said I wasn't gonna get into the weeds, no, it's fine, because I was afraid of taking too much time, but Elizabeth actually just put the more human face on it. It's really about not nitpicking over people's lives. I mean, thank you for putting the more human face on it.
Thank you so much. So I wanted to ask one more question on long-term care, which is more focused on the services. One of the most recently sort of controversial questions in New York State budget has been about the Consumer-Directed Personal Assistance Program, or CDPAP, which is one of the major models through which you can receive Medicaid home care in New York if you're elderly or live with a disability. The governor has expressed a lot of concern in very emphatic ways about the growth of this program. In the last budget, she proposed a very significant wage cut for the 300,000-ish people who work in this program, providing vital care to New York's elderly and disabled population. There have been sort of two big directions, I think, in the last budget for reform here. One was what Senator Vieira has discussed, the possibility of eliminating managed long-term care from the system to cut out a middleman and save some money through lower administrative burdens. The other, the one that was actually ultimately passed in the budget, was to eliminate the fiscal intermediaries who employ or who finance this care and replace them with one statewide single fiscal intermediary. Again, that was enacted in the last budget, but advocates and fiscal intermediaries continue to fight it. I wanted to just ask, what should New York State be looking at, if anything, to save money on this program? Is the single fiscal intermediary the right solution? And where do we go with CDPAP?
You should go back to the budget debates. So when the Republicans were asking the questions, they were like, "What do you think? Why are you suing this CDPAP thing?" And I said, "Actually, it's the best that we could get. I don't like it either." And they were a little confused. They didn't want to debate me. And I'm like, "Nah, I agree with you. You're right. This is a boneheaded move. Going from 600 there. Let me be clear. I absolutely think that the program needs to be changed and reformed. We do not need 600 FIs, but from going from 600 to 1 in the timeline, and also picking the one that they picked, there's all sorts of red flags here. And for anyone in the administration or anybody else who's telling me, well, you know, this is far too far down the path here. It's like it's already this ship has sailed and all this sort of stuff. I have two words for you: congestion pricing. and unlike that debacle, there is actually a reasonable option here. The bill that I've introduced, which again I encourage the governor, take the whole thing, make it yours. What Cali call that Catholic local reform? I don't care. Take it. It actually proposes a reasonable timeline, so it talks about a year. It also sets up really strict standards for fiscal intermediaries, because yes, there are bad actors currently in the system, but we can actually get rid of them if we make sure that we don't allow them to advertise, if we make sure that there's past actions means that they can have their license either taken away or not received in the first place, et cetera, et cetera, et cetera. There's a lot of things that are baked into this. So I think that let's not, the way I've been talking about is this is not about throwing the current governor's proposal, I believe, is not throwing out the baby with the bathwater. It's leaving the baby in the bath and then electrifying a little bastard. So let's not do that. Let's actually go a more reasonable option, and that would be making sure that we transition in a timely manner and setting up higher standards for these fiscal intermediaries. Because let's make sure that we focus on the folks who are being served, and the transition. My concern is, last thing I'll say about it, the concern that I have is that if the transition is messy, and it very likely shall be, then a lot of people, then we are definitely going to save on the system. Because there's a lot of people who are going to fall off the rolls because they're not going to be able to manage the transition. And if that happens, then yes, we're saving money on the program, but then what happens to those individuals who still need the service? It means that they might wind up in nursing homes, emergency rooms, or worse. So let's not do that. And this actually is the last thing I'll say about it at this moment. I do not believe that saying that is being fear-mongering. I don't think I'm being fear-mongering. I think I'm talking about from the experiences of the individuals that are receiving these services, the type of experiences that they've told me, the difficulties that they've had. It is likely that many of them will fall off the rolls if this is not done in a more elegant, in a more reasonable way. So I'm really concerned about this transition.
I want to remind us how the Consumer-Directed Personal Assistance Program came about. This grew out of the independent living community. So this was designed by people. And the reason that this came about, the reason that we have this program, is because for, I don't know how many years, probably someone in this room knows, but I don't, how many years we've had a home care workforce crisis. And it began in like pockets around the state. And now it's really a universal problem, and it's an enormous problem. And the reason this program came about is because people couldn't find home care workers. They just were not available. They would be eligible for services. The home care agency would, approve the hours, and the hours were abundant and whatever they needed, and they just couldn't find the workers. And so that's how this program started. It was a creative way to solve the problem of not being able to find the workers. And gutting this program, and I don't need to say more than what the senator said, but we support the notion that there could be a really smart way to do this through a certification process and rules and all of the things.
Thank you. Yeah. I'm realizing we have a little bit of extra time, so I wonder if I can ask, and Elizabeth, I think I'm going to start with you, about primary care.
That's what I wanted to know.
Primary care is really important. It's the entry point into the healthcare system. The U.S. and New York have faced a very long-standing lack of investment in and shortage of primary care, and I think Medicaid could play a role in solving that, and I wonder if Elizabeth does too.
Yeah, I actually think I think it's really important. I think I've mentioned this over and over again, that we have an all-payer approach to many of our healthcare problems, and I think this is a really great area. In that, remember I said healthcare expenditure in New York State is the second most expensive in the country, and of that spend, so that's bad, right? We don't want to be in the top 10 even, right? But even if so, assuming we spend more on healthcare, of that spend, 40% is on hospital care. On the other hand, our primary care spend is very depressed, and the amount of investment and about the number of primary care providers is also very depressed, below the national average, or like sort of middling in the States. So how do you invest in primary care? Well, other states have tried this and figured it out. I'm an insurance person, and we have a Department of Financial Services that has, before even the Affordable Care Act, grabbed back its ability to regulate health insurance companies' rates. And I would say we should do what Rhode Island does, which is really bend the cost curve and have a requirement, a benchmark amount that each out of every premium dollar, 12 cents, is spent on primary care. Like that's, other states are moving forward, that Delaware, Colorado, Oregon, whatever. And then have the superintendent of insurance's job be to, I'm not gonna approve another, we just approved 13% rate increases, right? Like that's, and then a very high amount. It used to be like 5-6%, but we just did Emblem asked for a 55% rate increase. So I'm not saying the department slacked off here, I'm just saying 13% is high, and we should not approve another % of rate increase until those insurance carriers do their job and actually regulate what they're spending their money on. And they shouldn't be spending it on expense. Oh, and the other piece that I missed in my whole little story here is that we have an extraordinarily high incidence of hospital emergency admissions that are preventable. So could be dealt better by primary care doctors. And having people in the emergency room is the stupidest and most expensive way to treat some kind of primary care event, right? We don't want primary care to be treated. We don't want hospital solution to be, oh, I'm just gonna affiliate all the local primary care doctors with me and then charge the hospital rate for those office visits. No, that's all wrong. That's called private equity. We don't want it. So I think we really have to think about our primary care investment seriously in an enforceable manner. You have a bill, which is awesome, to actually report how much each carrier is spending on primary care. And again, this would be, I would like see you and raise you one and say, no, make it an enforceable one. Like, let's have, and then the Commissioner of Health can enforce it through her rate setting process. I mean, they keep changing. But now it's a boy. It's just male identified person. He should be through his reimbursement negotiations with the health carriers for Medicaid, managed long-term care, for all those health carriers. He should also be demanding that at least 12% of the spend is spent on primary care.
We actually have a bill to make that happen.
Excellent.
Over the period of time. Like there's a bill, 1197B, which would actually require health plans, including Medicaid, to increase spending on primary care up to 12.5% over a period of time.
Yeah, I'm sorry, I thought that was a reporting bill, not an enforcement bill, but I got that.
That's an enforcement. So
Okay.
that is it. It's fine. It's like,
But yes, so definitely.
90% right. That's the 1%. So I have a bill, but yes, in your contact.
That bill is not new. That whole idea is not new. And in this year's budget, the hospitals got, I don't remember, was it 10%? I think the hospitals got it, whatever the rate was. The hospitals got a Medicaid increase this year. Primary care did not, despite the fact that they asked for it. So I'll put that out there to say, like we said earlier, the hospitals come knocking, so do the primary care providers, including the federally qualified health centers and other community health centers, and they didn't get it. And so I think that says a lot about where our priorities are at the moment, and we need to change the priorities.
Thank you. Speaking of priorities, and I think this is going to be our last question. My colleagues' work at FPI has shown that the state tax receipts are strong. We have a growing economy. It also looks as though the MCO tax that was authorized in the last state budget and may generate billions of dollars in revenue for Medicaid is moving forward, as near as we can tell. And so there will be some funding available for Medicaid, for new investments in Medicaid. That funding, as we just touched on, is always really profoundly shaped by the power and the lobbying of stakeholders with billion-dollar budgets. It's also shaped by the work of advocates like those on this panel. I wanted to ask just each of the three of you, what should we be prioritizing in the next state budget besides the New York Health Act? And let's make it interesting. Maybe top three. What would be the top three things that New York State should be investing in to expand healthcare access through the Medicaid program and build a more equitable health system?
Well, I would definitely start with coverage for all. Like, why it just is irrational to have immigrants not covered when we can get the 100% federally funded, so why not? And then we would also be able to bank and book those emergency Medicaid savings, so I think that would be fantastic. I also would get rid of the Medicaid asset test. And then I think I would pass that primary care spending, requirement, enforceable primary care spending bill. And then finally, I'm gonna do 4, I'm sorry. I think it's time we really rationalize our health planning system and go back and do what, take what California has and have an Office of Healthcare affordability, accountability, whatever it is. We just need to have some kind of independent planning, reimbursement, all-payer reimbursement mechanism that's run by an independent entity, because it's not working. We're all just paying way too much for healthcare in New York State on the wrong things.
I have a feeling we're all gonna say the same things, or largely the same things. Absolutely coverage for all. Not because it would cost the state money, but because it would free up money elsewhere. I don't have 3 defined things, I guess I would call them areas. 1 defined thing, coverage for all. In the area of long-term care, we need to invest in the workforce. The crisis isn't going away. The Fair Pay for Home Care campaign is renewing its efforts to make sure we have an increase in the home care workforce wages. There are some restrictions in long-term care that were put in place by the Medicaid redesign team in 2020. It was the 2nd iteration, and the division of the budget decided to put they figured out that they could put really huge fiscals on those cuts. And one of them in particular that would restrict access to long-term care based on the number of activities of daily living that a person needs in order to qualify. I don't know what the fiscal is, but let's just do away with that and repeal that really restrictive component of long-term care eligibility. And then the 3rd category that I would say is like a kind of a bucket of consumer interests, like the asset test, continuous eligibility, primary care. There are a variety of other things that really wouldn't even cost that much, that would make a really big difference to New Yorkers.
I think we'd very much like to say a similar thing, except I'll do a joke at the end of it, but that's
Thank God.
like I just said right there. But I think all of those things are certainly there. That bill, by the way, is mine to get rid of that imposition from the activities of daily living, and that's been my bill.
I mean, let's just say that most of the bills carried by Senator Rivera, because you're our champion. Credit to others as well, but yes, I should have said the ADL bill is also Senator Rivera's
Yes,
bill.
that's also my bill. It's I don't pick up easy ones. I haven't named a lot of bridges. Let's just say that. But no, seriously, no, not stadiums either. No, not that either. So the only thing I would add, all of the above, first of all. But for me, I've been telling my staff that I think that we need to prepare ourselves. I think next year's going to suck. And what I mean by that is that I'm going to have to play more defense than usual. For example, there's a bill related to setting up a system or setting up a procedure for hospital closures that I passed near the end of the year. It hasn't been signed yet. I have an inkling that the governor might actually veto that, which we'll have to fight over that again. We're already been talking. There's just the whole CDPAP thing that we've been talking about already. That will be in the middle of because as I said, I'm still opposed to it, and I still would think that there's a more reasonable way to do it. There is already, the administration has already told all agencies that they would require flat funding requests for next year, which probably means cuts for the Medicaid system, et cetera, et cetera, et cetera. And that's even discounting whatever might happen in 12 days at the federal level. So I'm certainly gearing up to reintroduce all of these bills in the next legislative session. I'm hopeful that I will do it with a couple of new colleagues who are going to be fighters, and that will have backbone when the going gets tough. But I really will gear myself up for what probably will be a very. I will have to put up. I'll say it this way: I'll have to put up a better defensive efforts than my Knicks did against the Celtics just a couple of days ago. But you know what? It's only Jesus Christ could shoot better than the Celtics.
Wait, go Liberty, go Liberty.
Yes.
I'm not happy about
This
it.
is how much Liz cares about policy. That's the parade. And just
I should have worn my sleeveless like that.
It's-
I have a jersey.
so the last thing I'll say is I am very much everything related to Medicaid. Certainly, that's going to be everything related to everything we talked about here, as far as primary care, as far as long-term care, etc. But I also would expect that regardless of how much certain people on the second floor don't hear me and don't hear us, we need to tax the goddamn wealthy, and we need to make sure we get veterans revenue by doing that. And I will continue to insist that we need to put these forward, that we need to push these procedures, these bills forward, because we need to generate more revenue that we can then invest in systems that not only save us money in the long term, but create better life conditions for all members.
Yeah, well said.
I was actually, yeah. Thank you all so much. This was a really rich, fascinating conversation.
Not as rich as those people we want to tax.
There we go. There's the joke. We hit it. That's it for us on Medicaid, but we will be back at 11:15 for our first really exciting housing panel. We'll start promptly at 11:15. Until then, thank you again.